Welcome back, everyone. Today we are diving into one of the most clinically packed rooms in the human body. We're talking about the axilla, the armpit. But forget the deodorant commercials. I want you to visualize this as a high-traffic transit hub. If the neck is the terminal, the axilla is the grand central station where everything important passes through before reaching the arm. Dr. Sarah, are you ready to break down the architecture?
Absolutely, Dr. Khan. For the boards, you have to think of the axilla as a four-sided pyramid. It has an apex, a base, and four distinct walls. Understanding the real estate of these boundaries is the only way to track where the neurovascular structures are hiding. Let's start at the top, the apex, or the axillary inlet.
Right, the apex. I like to call it the neck-to-limb gateway. It's a narrow triangle. Think of it as a bottleneck formed by the clavicle in front, the scapula behind, and the first rib medially. If you have a fracture or a tumor here, that gateway gets crowded fast. Why does this matter clinically? Because if that space narrows, you get compression. It's the root of thoracic outlet syndrome.
Exactly. And moving from that narrow apex down to the floor, we have the base. This is simply the skin and the thick axillary fascia. But the real high-yield facts for exams are in the four walls. The anterior wall is easy to remember. It's the pectoralis major and minor. If you're performing a breast exam and feel deep behind the muscle, you're palpating the anterior axillary lymph nodes.
And the posterior wall is the muscular backdrop. It's the subscapularis, latissimus dorsi, and teres major. I always tell my students, if you can't remember the posterior wall, just think of the muscles that help you do a pull-up. Now, Sarah, tell them about the medial wall. This one is a favorite for examiners.
The medial wall is formed by the upper ribs and the serratus anterior muscle. High yield alert. The long thoracic nerve sits right on the surface of this wall. Unlike most nerves that are tucked away for safety, this one is superficial. Why does this matter clinically? During a radical mastectomy or a chest tube insertion, if you nick that nerve, the patient gets a winged scapula. They won't be able to push against a wall or raise their arm fully.
It's such a classic board question. Now, the lateral wall is the narrowest. It's basically the intertubercular groove of the humerus. I think of the axilla like a tent. The humerus is the tent pole. If the pole shifts, like in a shoulder dislocation, the whole tent collapses on the nerves inside. Let's talk about the contents. What's inside the fatty space of this pyramid?
It's a bundle of lifelines. We have the axillary artery, the axillary vein, and the real star of the show, the brachial plexus. Remember the chords of the plexus, lateral, medial, and posterior, are named based on their relationship to the second part of the axillary artery, which is tucked right behind the pectoralis minor.
Let's put this into a real-world scenario. We have a 64-year-old woman who falls down the stairs. Her shoulder loses its rounded shape. It looks flat. She has swelling below the clavicle, and she can't feel the skin on the back of her arm or her thumb. Sarah, what's the anatomical diagnosis here?
That loss of curvature is the giveaway. It's a subcoracoid dislocation. The head of the humerus has been forced medially, so it's no longer pushing the deltoid out. Because the head of the humerus is now sitting in that axillary space, it's crushing the axillary nerve and the radial nerve. That's why she has sensory loss in the regimental badge area and the back of the forearm.
Spot on. To be the doctor of choice for a patient like this, you can't just look at the x-ray. You have to test those nerves. If you don't know the axillary boundaries, you won't realize that a humeral head sitting under the coracoid process is essentially a wrecking ball for the posterior cord of the brachial plexus.
And we can't forget the lymph nodes. There are 5 or 6 groups of axillary nodes. They drain the entire upper limb and, crucially, about 75% of the lymph from the breast. When we talk about breast cancer metastasis, the axilla is the first place surgeons look. If the nodes are fixed or hard, the cancer has likely breached the pyramid's boundaries.
I love using the filter analogy for those nodes. They are the security checkpoints. If they are swollen and tender, it might just be an infected cut on the finger. But if they are painless and hard, the security has been overwhelmed by something more sinister. Why does this matter clinically? Because the level of node involvement often determines the stage of cancer and the extent of surgery. Precision is key. Even the claviopectoral fascia matters. It's the curtain behind the pectoralis major. It protects the neurovascular bundle, but it's also pierced by the cephalic vein and the lateral pectoral nerve. If you're a surgeon, knowing exactly where those structures pierce the fascia is the difference between a clean procedure and a complication. So to wrap this up, the axilla is a pyramidal transit hub. The walls protect the cargo, the artery, vein, and nerves. When the architecture fails, the cargo gets damaged. Sarah, give us the 30-second high-yield summary.
You got it. Boundaries. Apex is the neck inlet. Base is the armpit skin. Anterior wall is the pectoralis muscles. Posterior is the lat dorsi and subscapularis. Medial is the serratus anterior. Lateral is the humerus. Contents: axillary artery, vein, and the 3 cords of the brachial plexus. Most important clinical link: shoulder dislocations and mastectomy surgeries are the 2 biggest ways the space gets compromised.
Perfect. Knowledge of the axilla isn't just for anatomy class, it's for saving function in the hand and identifying the spread of disease. Thanks for joining us today.